and an essential step in creating an effective curriculum that addresses AI is gaining insight into how medical students view artificial intelligence and its applications.
Sorry, Dr. Sawa. We are only seeing the first slide. I think it's not changing in our end.
Oh. Can you see it now?
Yes, yes.
Okay. So the objective of the research was to assess the perspectives of medical students on artificial intelligence. Specific objectives were to assess the knowledge of medical students on artificial intelligence and to assess the attitude of medical students on using artificial intelligence in medicine. Methodology, so a cross-sectional study was conducted among medical students attending medical universities in Addis Ababa, Ethiopia. Questionnaire was distributed online to identify the perceptions of AI among preclinical and clinical year medical students from January 2025 to March 2025. The questions were adapted from a similar study done in province in India, which was published in 2024. So for sample size calculation, a single population proportion formula was used to calculate the sample size. So assuming a prevalence rate of 84.9%, based on findings from a previous study and with a 95% confidence interval and 5% margin of error, and adding 10% non-response rate, the final sample size was calculated to be 217, and convenient sampling technique was used. Our source population was all undergraduate medical students who were attending medical universities in Addis Ababa, Ethiopia, and the study population were all undergraduate medical students who chose to participate in the study during the study period. And eligibility, all medical students, as long as they consented, were eligible to participate in the study. uh, Variables, the outcome variables were the knowledge and attitude of medical students on artificial intelligence in medicine, and the exposure variables were age, gender, prior knowledge on artificial intelligence, and year of study. Our operational definition, knowledge of artificial intelligence, was defined as knowledge, any knowledge gained in school or elsewhere through various trainings. And attitudes of artificial intelligence in medicine was defined as the perceptions of medical students in using AI in medicine, as well as learning about artificial intelligence in their medical school. Data collection and quality assurance. Data was collected using self-administered Google Forms. The questionnaires collected demographic data, previous knowledge and training on AI, and self-perceived level of knowledge on applications of AI in medicine. Furthermore, Likert questions were used to determine the perceptions of participants on integrating AI in medical education, as well as on the ethical aspects of using AI applications in medicine. Data was managed and analyzed using SPSS version 26. Ethical clearance was obtained from Addis Ababa University College of Health Sciences, and informed consent was taken by participants at the beginning of the survey. This consent ensured the participant anonymity by not collecting any identifying information, such as names. Some of the results we tried to show by table. So majority of the participants were females. And preclinical year medical students comprised over 50% of the participants for this study. So some of the questions that were asked were, so for the question, have you received training in AI in your medical school or elsewhere? Majority, around 80% of the respondents said that they had not received any training on AI. in medical school or elsewhere, whereas less than 15% said that they took some courses as online trainings, or they attended seminars or presentations, or they took a course. And regarding their self-perceived knowledge of AI and its applications in medicines, less than 10% said that they were knowledgeable on AI in medicine, and around 34% said they have heard about AI in medicine, but they possessed no knowledge about it. And around 6% reported that they had no knowledge of AI and its applications in medicine. And there was a statement, we asked them, how much do you agree with the statement, the use of AI in medicine reduces the need for physicians and thus employment opportunities? Around 40% were unsure about this statement, and only about 30% disagreed with this statement. So to summarize, a total of 170 students participated in the survey with a 78% response rate. The mean age of the participants was 21 years, and females comprised 67.1% of the respondents. Majority of the participants attended Addis Ababa University, and 30% were from St. Paul's, and only 0.6% attended Bethel Medical College. Regarding their prior knowledge and self-evaluation, as I stated, the majority of the students said that they had not received any training in their medical school or elsewhere. And around 34% of the participants said that they had heard about AI and its applications in medicine, but they had no knowledge of it. Around half of the participants stated that they had partial knowledge of AI in medicine, but only 10% that said that they were quite or very knowledgeable on the subject. Regarding with the use of AI in medicine, more than half, around 79.4% of the participants agreed with the statement that AI could not replace physicians, but could assist in their work, while 28.2% of the participants agreed with the opinion that AI could reduce the need for physicians and decrease employment opportunities. Regarding the possible influences of AI in medicine, a greater number of the participants agreed with the statement that AI facilitates physicians' access to information, enables physician accuracy around 84.1% of the participants, and it's around 83.5% of the participants said that it facilitates patient education. The majority of the participants also agreed with the statement that AI reduces errors in medical practice, which were around 78.3%. Around 82.9% said that it facilitates patients' access to service. And around 63.5% of the participants agreed that AI allows patients to have more control over their own health, and 50.6% agreed that AI increases patient confidence. The lowest percentage of agreement, which was around 22.9%, was seen with the statement that AI devalues the medical profession. 24.7% agreed that it negatively affects the relationship between physicians and patients, and about 1/3 of the participants agreed with the statement that AI reduces the humanistic aspect of the medical profession. 29.4% of the participants were in favor of the statement that AI damages trust between physicians and patients, and 37% were concerned that violations of professional confidentiality may occur. And on the need for AI education in the medical curriculum, around 93.5% of the participants were in favor of a structured training on AI and its applications during their medical education. So these were some of the results we saw after we collected participants' response from the online forms. So when we come to the limitations of the study, the participants were only from 3 medical universities in Addis Ababa, and the questionnaire was distributed using online Google Forms, and this could introduce selection bias, and the sample size was small, and this limits generalizability of the findings. In conclusion, so with this study, we tried to shed light on the perspectives of medical students on the inclusion of artificial intelligence in their medical curricula. And there was a lot of gap in the knowledge of AI and its applications in medicine. Furthermore, medical students were highly interested in learning about AI in medical school. And integrating AI education in medical curriculum will not only increase knowledge about AI's practical applications, but also ensure that future healthcare providers are prepared to manage ethical challenges and potential impacts AI may have on healthcare practice and patient relationship. And these are some of the references we used. And thank you.
Thank you, Dr. Sawa, for the nice presentation. Now we'll move to the review sessions. We'll hear back from our reviewers. And at the meantime, I'll encourage our audiences to comment their questions in the chat box. I'll make sure to compile them and ask Dr. Sawa at the end. But I want to remind everyone this is educational session and the question should be, for learning purposes. It's not confrontational, it's not graded. So please see it from that way. And our first reviewer is Dr. Abel Meste Makonnen. He's a physician and a digital health advocate. He's a founder and voice behind Digital Health Digest. Dr. Abel is currently serving as an advisor on emerging technologies in AI at the Ministry of Health. His international experiences span from leadership roles such as Chief Program Officer at Mobi Health International in Nigeria and Digital Health Consultant at Chemonix International in the US. He also served as a country director for Bridge Center for Impact, digital health advisor at Medifra, and he is a digital health project manager at Orbit Health. In addition, he co-founded an Optimal Delivery and Operation System initiative. Dr. Abel holds a Doctor of Medicine from Howard University and a Master's in Data Science and Information System from Mozilla University. He has also earned for professional certificates in digital health from Imperial College London and Johns Hopkins University. He is currently a public health informatics fellow at African CDC. Without further ado, I'll invite Dr. Abel to give his comments. Thank you.
Thanks so much, Dr. Pirobel and the Medical Research Lounge team for the invitation. Dr. Sabah, you presented a wonderful findings, and I'm happy with what you have achieved. So as we all know, artificial intelligence in healthcare is currently the hype. Even though there are a lot of gray areas, everyone is trying to, come up and support and optimize the healthcare system. So I have a few questions and recommendations on some parts. I have tried to go through the abstract and the questionnaire shared earlier. So my first question, you don't have to answer them now, but just try to maybe incorporate them later on. So the first question is regarding to the methodology, especially on the questionnaire design. So I thought that you mentioned, and I saw in the document, the questionnaire was adopted from an Indian study and was later edited to be understood. My question is, did you go through some kind of validation process? For example, any validity check by local experts or any debriefing within the school or with just a small student group, or were there any reliability testing done before it was distributed? Maybe as just as a recommendation or just as a suggestion. Usually, it's advisable to clearly document when we are adopting from other countries, other continents, to clearly document the reliability and validity data, so that it will be easier for us. Sorry about that. It will be very easier and good for us to localize it within our ecosystem. So if there were no any formal testings done, maybe this is maybe in the future one of the critical steps for future studies to ensure such kind of measures findings would be reliable within our country's context. The other question I had was regarding to the Google form you distributed. There is a mention of convenience sampling via the Google form. For this will lead to more of a digital savvy students to participate. Given that within the findings, I think it was 41%, it mentioned that they were unsure regarding AI reducing employment. So how might this selection bias toward students with some AI exposure have influenced the large size of the uncertain group? Maybe you can actually use this finding for to advocates for targeted pre-training assessment, especially within the specified medical schools within the city. The other one is my question is regarding AI. The document, even the Google form, was using the term artificial intelligence AI. So was there any clarifications done before sending out these Google forms? Because when we talk about artificial intelligence in healthcare, we have so many things. We have so many tools. We have so many implementations. Are we talking about machine learning? Are we talking about LLMs? Are we talking about it's just clinical decision support? Because AI, one of the major aspects of implementing AI is to optimize our workflow, especially if we are implementing EMR or EHR. By using AI, we can actually sort and optimize our clinical decision support workflow. So my question is, was the term initially uniformly understood to include concepts like basic informatics, or is it statistics, or only machine learning? So because this will help us in the recommendation part when we are reporting training gap, we can suggest like how should be such kind of initiatives or any support should be focusing on solving or mitigating such kind of gaps. The other question is I think on the results and discussion points. The results state that I think 81.8% had no training, and it also mentioned that 50% of them claimed partial knowledge. So my question is, did you? I don't see, but did you plan to have any discussion on attempting to explore the potential source of this partial knowledge mentioned? You can mention about social media, popular press. It could be any exposure through previous engagements where students are currently learning about AI. So that you can add the discussion on, or it can be expanded to hypothesize the non-formal learning source as well. So this will also suggest the need for more of for the educators to actively monitor and also integrate content that addresses such kind of informal knowledge students are actually getting or capturing. My other question is regarding to the ethical and humanistic concept, because when we discuss about AI, currently we have a lot of policies, standards which are available online regarding to uh, AI and ethics. The abstract actually compares the 60.5% of Ethiopian students agreeing that AI reduces humanistic aspect. And then we have another percentage, about 90% found in the German study. And my question is, what are the cultural or educational factors that might explain the significant difference in the level of concern regarding the humanistic aspect between the two groups? This actually might help you in the future to scale up this research and make it more of a mixed method study, so that you can also, not only the students, but you can also give insights on comparing the different medical culture and the way such kind of curriculum are in place. My last question would be on the recommendation part, that is on the conclusion. There is a reference to the World Medical Association's recommendation to review the curricula. Cool. So with the findings, with the study's findings, how do you intend to present these findings to your university, to the ones mentioned, the Addis Ababa University, the St. Paul, and other medical colleges, so that this can actually help them in going through, and it will be an input in facilitating the curriculum review, and also this such kind of findings can in fostering more of a deeper understanding on AI in healthcare. So if there are, maybe you can mention if there are any plans or if there are any dissemination plan for the findings. It could be presenting more of a formal policy brief to the university's head or dean, or you can also further go and have presentation on different seminars, so that this can be a good input and also further advocate for curriculum review, not only on AI, but also we have been discussing about incorporating digital health within our medical curricula. So to some of my questions. Thank you so much, and let me know if there is any suggestion or question directed to me. Over to you, Dr. Kluge.
Thank you, Dr. Abel. I think now we can move on to the next reviewer, and I'll let Saba answer all the questions all together after compiling the questions coming from the chat box as well. So the next reviewer, I think you're familiar with her. She's Dr. Tigist Orkana. She's the founder and general manager at Medical Research Lounge. I think without further ado, I'll invite Dr. Tigist.
Thank you, Dr. Kirba. You can hear me, right?
Yes, we can.
Thank you. Thank you, Dr. Saba, for the wonderful presentation, and most importantly, the fact that this is your first presentation as a newly graduate medical doctor. The fact that you were interested to present your research article for the public and get a feedback is a very encouraging thing for everyone here, including myself. I hope this will be a very good learning experience for you, and you can take these comments for the future and try to work on something much more interesting than this. So I share all the comments that are forwarded by Dr. Abid, so I'm not going to repeat those. I'm going to focus more on the methodological aspect of the research, but I have very few minor comments on the intro and the general formatting of the paper. Let me start with that. So in general, when you present your article as a PowerPoint, you have to use a Harvard style of citation instead of the Vancouver. You have used the Vancouver style, and it's difficult to tell what the reference is actually if you're putting numbers. So change that to Harvard style. And in the introduction section, you have only cited very few references, like from the main document. I've picked only 8 references. So, but in the discussion section, you have added much more relevant and comparable articles to compare it with your findings. So those references, you have to bring them up to the introduction section and synthesize them very well and convince us what was the gap that you saw in conducting this research. So these are very important but minor things that you can address later. And when we come to the objective, can you please display your slide on the objective? Yeah, so these objectives are like, let's focus on the specific objectives. They both are just descriptive objectives. You know, there are 3 different, you can have 3 different sets of objectives. The first one is descriptive, purely an objective that seeks to measure the prevalence or incidence of something, the proportion of something, just like here to assess, to determine the level of knowledge, to determine the level of attitude. And it can be an inferential objective where you can assess factors associated with these outcomes, like what are the factors that determine level of knowledge or level of attitude. Or you can have a combination of both. So here you have just presented the descriptive objectives, and it looks like your intention was just to assess what was their level of knowledge and attitude. But in the main document, you have reported inferential results, which were a bit confusing, but I think you have omitted them here. So if you didn't do any of those things, we can skip them. But if you have an inferential report, like what were the factors that affected, did gender affect the level of knowledge, the level of attitude, then it's an inferential objective. That means an analytical study, and we expect to see the results based on which you have reported those findings. So I think if you don't have that, we can skip it. So when we go to the method section, I don't understand why you have selected these 3 institutions. Was it because of convenience? I mean, you have used an electronic data collection tool, so convenience cannot be an issue at this point, but you have restricted yourself to only 3 medical schools in Addis. And as you can see, the sample distribution was a bit skewed. The private medical college that you have included, which might have even better exposure to AI-related content or teaching or training, was like 0.9 or something like that. So the fact that the sample distribution was a bit skewed might also reflect on your overall result that you have reported. And why was it restricted to just these 3 medical schools? What was the reason? Because associated with it, you have encountered a problem. The sample size that you have calculated was something like 217, right? Can you please display your slide on the sample size? It was 217. But at the end, you have only interviewed 117 participants. This clearly shows that your sample size, the sample size that you have finally achieved, is not adequate to provide any sort of like recommendation for this study, because you have estimated that the minimum required sample size is 217, right? but you have achieved 117. There are other medical schools. If it was like all the medical schools within the three colleges, all the medical students within the three colleges, if they add up to 117, then you have to include other medical schools. So this again raises a big bias and fires back to your own sample size justification process and the fact that there are ample medical schools in Addis or even in Ethiopia. So that will be a problem. And the other is, since you've used a Google form for collecting your data, and if the intention was to truly understand the knowledge and perspective of medical students in their knowledge and perspective of AI and its application in medical field, then why didn't you study like all medical students in Ethiopia? I think you can access them through the Ethiopian Medical Students Association platform or some other thing, and you could have collected their data. So what was the justification? How are you going to justify this? And the other is, you said you have used convenient sampling method. Well, in quantitative research, using convenient sampling method is not justifiable, is not the proper method for sampling. Rather, it has to be representative. That's why we use a representative sampling method for quantitative research. Well, if you are trying to say you have used a census sampling method, that might make sense. That means you have included everyone, every medical student currently enrolled within the three facilities during the time of the study. Then that's a census sampling, that's acceptable, but convenient sampling is not acceptable. So when we go to the most important, the most critical part of the method section is your operational definition. Dr. Abel has also commented on that part. You said you have adopted the questionnaire from just a random study in India. Whenever you refer an article to just adopt the questionnaire from that study has to be some like international study or a tool validation study or some guideline which guides you to use some sort of validated tool for a particular topic. But this is just a study. We don't know where the authors get these questions from. You just use that study. And yes, you mentioned that you have edited it to be understood by the participants, and you have removed some of the specialization related questions because your focus was on undergrad medical students. But this is not justifiable. Just adopting something from a different study, which was conducted in a completely different setting, without questioning it and without assessing its internal or external validity is not acceptable. So at least the least we can do is, you can do is like, you could have assessed the tool that you have used, the tool for which you have collected data, you can assess it for internal validity. You could have done that, but I think it's not reported in the study. But still, you can run that and show us whether there is at least internal consistency of the tool that you have used to assess these parameters. So when we come to the outcomes, I have tried to collect some of the terminologies, the variables that you have mentioned throughout the paper, throughout the presentation, as outcomes. The first one is perspective, and then knowledge of AI, and then self-perceived knowledge of application of AI in medicine. And then there's attitude, and then there's perception. But you didn't report a clear finding for all of this. When you have outcomes that you have listed in order, we expect to see a single report for all of them. What was the prevalence of these outcomes? Like imagine you're studying patients with hypertension and your intention was to see how many of them have uncontrolled blood pressure. So at the end, you'll want to see the prevalence of uncontrolled blood pressure among the study population, these many percent, these many percent. So just like that, whenever you study knowledge, attitude, perception, and stuff like this, you also have to report a clearly defined number for these things. Yes, these things are not just something that you can measure with a single question as a yes or no, a yes or no end report, but rather these are variables that you have to assess based on a number of questions that are validated, standardized, as I said before. And then based on those questions, you summarize, you calculate a total score for that particular variable, let's say knowledge, and then for that, based on that score, you can further classify it instead of just reporting that their mean or median knowledge is this much, you can report, which is the most common way of reporting and the most understandable practical one is to say whether they have favorable or unfavorable knowledge, good or I don't know, good, bad terminologies are actually not good, but you can use favorable, unfavorable knowledge, attitude, and perception. But here you did not report anything like that. Rather, you have reported just the breakdown of the results. You were mentioning like the result section was so bulky. You just reported these many percent agreed with this idea, this many percent did not receive training and other things. So most important question from my side is, what were clearly the outcome variables? There are 5 things that you have listed throughout the manuscript, but from your objective, what we expect to see is knowledge of AI and attitude. So stick with that and show us clearly what the definitions are. What you wrote here are on the operational definition section. Here are conceptual definitions. They're not operational definitions. Conceptual definitions are just regular definitions to define what that terminology or what that variable means. Operational definitions are different. These are definitions that where you show how you are going to measure your variable using what set of variables or questions and where that comes from, and you have to back up that with a standard reference. Otherwise, using a random definition cannot be justified as a proper research variable measurement style. So while we're at it, you stated that at the beginning of the results section, knowledge of AI, while trying to show the result for knowledge of AI, you stated that 81.8% did not receive training. There are 2 problems here. The first one is, if you want to talk about knowledge, there is no reason or there is no need to talk about training. That's a completely different set of things. Knowledge is something that you assess based on a set of questions that assess the understanding level of the participant. Whether the participant received training or not is not part of knowledge assessment. That's a prior assessment to decide whether to ask the participant about knowledge questions or not. So the second problem is, unless knowledge is something that you gain through training, formal, informal training, or through reading or something, you just cannot have that without any sort of exposure to that particular topic. So whenever you assess knowledge of something in any group, in any type of study, you have to make sure that there are ample resources for that participant to learn about these things. So if these medical students did not receive training, something like, I don't know, 18.2% did not receive training. If they did not receive training, if they do not have any other exposure to AI-related content and its relevance, then you can't even assess their knowledge because they're not exposed at all. And automatically, we know that their knowledge score is going to be below the expected. So training should have been, your result should be presented in this order. First, you ask how many of them are like exposed to AI-related content. And then from those who are exposed to AI content, you assess their knowledge and attitude, and you leave the rest from the analysis because those who did not receive training cannot be assessed for anything for knowledge or attitude because they're not eligible. So that should be corrected. And the others, like I said, the results are so fragmented. They should be pulled together, and you should show us what these questions are supposed to assess indirectly. Like, was it for assessing knowledge or attitude or what? It's not clear. And the perception result is also not reported. And the other is, most of the questions, they don't seem an objective question. Rather, they seem like a question that are like reported based on the individual's perception. Like for knowledge of application of AI in medicine, you reported that 34.1% heard about AI, but not knowledgeable. This is an information level. Like I said, those who did not hear about AI in medicine, they're not even eligible to be assessed for knowledge. So this is not even a proper report for that particular variable. The other is, they said 50%, around 50% say that they have partial knowledge. Knowledge is not something the participant is going to say, I'm knowledgeable or not knowledgeable. It's something that you assess based on a set of questions and give a score yourself and grade the participant. And this should be corrected. But I believe you have the right set of questions. What you need to do is understand how to measure each and every one of them. See if these tools, if these set of questions are at least internally valid, internally consistent. You can assess them using reliability assessments. Simply on SPSS, you can do that in a matter of a minute and see whether the results are consistent or not, and then proceed to measuring these results for the eligible part of the participants and compile the scores and give them like a cutoff point and label them whether they have acceptable, unacceptable, good or bad, favorable, unfavorable, knowledge or attitude. And based on that, you can forward recommendations. So most of the things seem to be very disconnected and difficult to grasp in terms of clearly communicating what the outcome variables are at this stage. So one question, maybe you can respond to this later. On the main document, it says that perception about AI not replacing physicians, but assisting them showed a significant association with gender. So was inferential analysis or regression analysis done for your study? Was there a component of the objective that wanted to assess the factors that are associated with these outcomes? If there are, it would be great if you share them so that we can forward our opinion. And so for the discussion, I'm not going to say much about it, because after you correct your results, then you have to guide your discussion based on the new results. So I'm going to skip that. So the last part, can you please display it on the limitation section? So limitations are, by the way, the section heading says strength and limitation of the study, but you just surrendered and talked about the limitation section, the limitations of your study only. It's very important that you also show the strength of your study. I think as Ethiopians, we all have a problem of, claiming what we deserve or what we have done, and that bad culture is following us even in research. Most of my students also do the same thing. After they report, they just go directly to the limitation of the study. You have to show the strength. My study, this is the first of its kind. I have included multi-centers and stuff like that and stuff like that. Then after that, you can show the limitations. So please add your strength when you submit it for a journal. And on the limitations parts, all the three limitations, they have their own problem. Limitations are the things that are associated with the methodology of our research, which we couldn't avoid due to the design of the study or the setting of the study and other uncontrollable factors. But what you stated here are clearly under your control. You say that the participants were only from 3 medical schools in Addis. So why didn't you include all medical schools in Addis? For that matter, why not all medical schools in Ethiopia? Like I said, since you have used an electronic tool, you could have sent it through the association to all medical students in Addis, even in Africa. I know that you have this platform where you access all medical students in Africa and others. So this is, somebody will be like, why didn't you include others then, right? So this is not a methodological flaw. Rather, this is the author's choice to stick to the 3 medical schools, and this is not justifiable, or this is not something, oh, this is understandable. No, this is not understandable. So the second is that the questionnaire was distributed using Google Forms. It could introduce selection bias. Again, the problem of convenience sampling that I have raised earlier. So even if you use Google Forms, we use electronic forms to make data quality better, not to replace the data quality assurance parts of collecting data using a paper-based tool. So even if you use a Google form, you have to make sure that all the selection methods, the sampling procedures are followed and other biases are avoided, right? So this is very important. And in fact, with regard to using Google form, there are definitely benefits to it, because you can say that the form was designed in a way that the participants cannot skip a question. So there was no non-response. Not having a non-response in your questionnaire is a good thing. So rather it has positive things. You didn't show us that. You just claimed that it affected your study due to selection bias, but it's not the form that caused this problem. It's your sampling method that caused this problem. So again, it will backfire at you, at your choice of design of the study. The third is the sample size is small and limits generalizability. Yes, but why? Again, you chose to stick to the 3 medical universities, even knowing that it's below your calculated sample size. So this is again something that will backfire at you, and it's not something justifiable, something acceptable. So these are not limitations, rather, these are the choices that are made by the author and that could have been prevented. So you have to work on these limitations if there is a room to add other medical schools and expand the study or other means. So for your conclusion, please make sure that after you correct the results section, make sure that your conclusion is results driven. And again, your recommendation is also result driven. Thank you.
Thank you, Dr. Tegest. Before letting Dr. Saba respond to the questions from the reviewers, I don't see any question in the chat box from the audience. But if anyone wants to ask question, please feel free to unmute yourself and ask your questions to Dr. Saba. I'll give you a few seconds if anyone has a question. I think we can let Dr. Saba respond to the questions. Please know that you're not expected to address each question individually. Feel free to summarize and provide a brief reflection on the questions. And I'll leave the floor to Dr. Saba.
Thank you, Dr. Abel and Dr. Tegest for the constructive feedback. I have learned a lot from the questions and the recommendations that I have gotten, which I hope to work on the paper more. So to address some of the questions, when we chose the questionnaire, we adapted it from we reported that we adapted it from an Indian study, and the questionnaire was also adapted from that questionnaire was also adapted from another questionnaire which was used internationally, and it was validated. So we thought that just like the study from the province in India, we can adapt it to our setup. And there was no validation process, but we tried to pilot test it on 5 medical students. And to the question, was the term AI specified? No, it was not specified, but we will try to maybe in future projects we will try to specify AI in this questionnaire. We defined the term AI to encompass any form of artificial intelligence, from large language models to deep learning machines and things like that. So to the question, how do you intend to present the findings? We plan to distribute the questionnaires to more medical universities. We had only responses from 3 medical universities. I think we try to distribute it online through online forums like Telegram groups, WhatsApp groups, and things like that. So these were the only responses we received. Some of the universities we tried to go and explain about the questionnaire and for students to fill them. So we had only access to these 3 universities, and that's why the response rate was limited only to these 3 medical universities. So in the future, we will try to get more responses from the various universities that are present. So again, I would like to thank the whole medical research launch team for giving me this platform to present my research paper and to receive constructive feedback. And we will work on the recommendations and the feedbacks we got to try to make the paper more to have a strong recommendation and to have a strong result. Thank you.
Thank you, Saba. Thank you, Dr. Saba. That was an interesting presentation, a very timely topic, and definitely a very good work for internship thesis. That was definitely better than what mine was. And I don't see any questions from the audience either. Please find a link in the chat box for your to collect your CPD points. And I think a very good closing statement would be AI will not replace us, will not replace physicians, but physicians who use AI will definitely replace physicians who do not. And before closing the session, I will ask Dr. Abel and Dr. Tegest if they have any comments. If not, I'll thank Dr. Sawa. Thank you, Dr. Tegest. Thank you, Dr. Abel, for your comments, and thank you everyone for attending our session. Please feel free to, I see Dr. Abel raising his hand. Please feel free to unmute yourself.
Okay, apologies for the delay. I was just trying to say if you need any help with related to digital health, AI, or emerging techs in healthcare, just let me know. I'll share my LinkedIn with you, and you can reach out to me whenever you need that support. Thank you.
Thank you. All right. Thank you, everyone. Have a great evening.
Thank you, Dr. Kiribel. Thank you, everyone.